Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of January 4th, first week of 2022, and as you can imagine, the huge news is Omicron and what it is doing with and to our country. Total numbers globally since the start of the pandemic are 295,490, almost 420,000, with almost 5 million deaths in the whole world from the start of the pandemic. In the United States alone, we are just over 57 million total cases since the start of the pandemic and over 830,000 deaths. More telling even is the last 28 days in which we have had 7.7 million new cases. That's a significant chunk of our total, as you can imagine, with incredible increases in our case loads, all due, I think, to the Omicron variant as it extends throughout the country. Fortunately, however, the mortality rate, while not flat, is not also exponentially increasing. So just the last 28 days, we're at just over 37,000 deaths compared to 800 and almost 31,000 since the start. So Omicron absolutely is the significant primary variant. Starting from a very first case in very early December, over 11 days becoming the predominant variant in this country. Now estimates are, as of this week, that Omicron accounts for just over 95% of all new cases. So that's fast. That's very fast. And I think none of us are surprised by that, certainly with the media coverage that we're getting. But in context, it took Delta almost 3 months to achieve this status. So Omicron did it in just 4 weeks. Huzzah. Kids, this is the report through the end of the year through the American Academy of Pediatrics. There are almost 7.9 million total cases since the start of the pandemic. That accounts for just over 17% of all cases and a rate of 10,484 per 100,000 pediatric age patients. Also telling, again, this is the week-by-week breakdown. Prior to this last week, COVID-19 in kids was accounting for about 20 to 30, around 30% of all new cases. It's down to 17.7% of new cases for the last week. So that doesn't mean there were far fewer kids being infected. It's just that the caseloads have exploded, especially among young adults and even older adults who are even those vaccinated but not yet boosted. So a lot of breakthrough cases occurring. And of course, those who are unvaccinated are still the vast majority of new cases. Fortunately, however, kids either are just not sick or asymptomatic and not presenting for diagnosis, and or are once again the less significant age group that's being targeted by Omicron. So the age group of focus seems to be those young adults. So here in Arizona, we have dropped, yay, to number 12 in the country in terms of our rate per 100,000 since the start of the pandemic. Our total numbers are 270,576 cases that have been reported to Arizona Department of Health Services and thus to the AAP since the start of the pandemic. That's 19.8% of our total cases, and our rate per 100,000 kids is 14,716. Compare and contrast that to the national rate of 10,484. So in case anybody is counting on this, we are getting closer in a good way to the national average, whereas before Arizona has stood out unfortunately ahead of the field. So that's a good thing. Unfortunately, we've recorded 2 additional COVID-19 related deaths in pediatrics since the last podcast. So again, this is and remains a very big deal. We have just one question, I think, just from the holidays, and it's not but it's a question asking about quarantine practices, isolation practices with the Omicron variant. So I think it'll be just a good reason to talk about Omicron, the new CDC recommendations, and also what we know about boosters. So First and foremost, the virus itself, Omicron variant, which I think most now realize was initially described in South Africa and neighboring Botswana. The initial report or reports rose and are thought to have emerged from a patient with HIV that was in poor control who may have been co-infected with a initial strain of SARS coronavirus 2. So something from an animal vector, meaning not a variant, but also co-infected with coronavirus OC43, which is a cause of the common cold, right along with rhinovirus. So this Omicron variant likely represents an antigenic shifting event, kind of similar to what precipitates influenza pandemics every 10 years or so. So a combination event of genetic material giving it both significant mutations, over 70 novel mutations over and above what we know of from others, and 30 within the spike protein. 10 of those 30 are within the actual binding site of the spike protein. So this is a significant virus in terms of its mutation rates, but it also has a different pathogenicity profile, and this is important. It's also still emerging, so take what I share with you with a bit of a grain of salt, because it remains yet to be confirmed. But animal studies and some initial human tissue studies suggest that Omicron variant does not infect lower respiratory tissues. Its tropism or its predilection is for upper airway tissue. So nasopharynx, oropharynx, maybe the trachea. So the patients are indeed presenting with symptoms far more consistent with an upper respiratory tract infection, the cold, the common cold, and fortunately are not presenting with significant lower respiratory tract disease. So they're not coming in as frequently with the multifocal pneumonias, with the severe respiratory failure, with the need for non-invasive ventilation, etc. All that said, there are far more people who are being infected with Omicron, both unvaccinated as well as significant breakthrough infections, and those who are vaccinated. So the sheer numbers, of course, continue to overwhelm the healthcare system, the emergency departments, and you get a tenfold increase in patients being infected. Of course, you're going to select those with underlying health concerns, with comorbidities, putting them at risk for and need for hospitalization. In the pediatric world, a majority of our hospitalized kids who are COVID positive have underlying reactive airway disease and or are full diagnosis of asthma and are coming in requiring additional treatments and oxygen for that. An additional population of hospitalized kids are those with special needs who may have underlying chronic lung disease and or just decreased respiratory reserve. So this is not to suggest that we're free and clear from major burden from Omicron, just that the personal risk of both hospitalization and severe disease is far lower individually than it has been with all the preceding variants. So yay, great, fantastic, that's wonderful, and it does appear that observation from the animal studies is borne out in population studies as well. Also, and here too are perhaps some additional morsels of comfort as we look at South Africa's experience, right? They were the first country in the first part of the world to experience Omicron. They had a very sharp, very nasty peak of tons and tons of cases, but also a rapid resolution. So Africa's peak is already, their surge is already mostly resolved, and they're 2.5 months into this. Similarly, and very importantly, their mortality rate, their death rate has not encountered a similar peak. So it continues to be sort of a either plateau or a very slow and steady increase, much as you would expect for just general underlying health concerns. So if that indeed is reflected in other parts of the world and the United States, then we may be right at the maximum peak right now this week, and hopefully about to encounter a decrease in numbers over the following several weeks. That would be great. Major caveat is that different populations, South Africa's peak was largely in unvaccinated, healthy young adults. Our peak is including that category, but also those who are older, those with underlying health concerns, etc. So we may have a prolongation of our peak or our surge, but hopefully we'll encounter the same shorter time period for the surge that we have experienced previously with beta, alpha, and now the delta variants. The other interesting thing, and again, another morsel of comfort, is that this variant, the Omicron variant, represents, again, a frame shift in how the virus is behaving. And it is possible, and in fact, the predictive modeling suggests that this may be our last major surge, that the virus is now evolving into endemicity by achieving sort of a safe ecological niche for itself. So it's becoming very infectious, but it is not killing off its victims as rapidly, which from the virus perspective is what it wants, right? It wants an ecological niche, a reservoir in which it can hide and live without causing major death, morbidity, mortality, and eradicating its safety position. So this may be the beginning of the end of the pandemic. Gosh, I hope so. I'm sure we all do. And at least the initial suggestions are positive and predictive that this may be what we'll experience going forward. So endemic little surges of similar to other upper respiratory tract infection viruses, where we'll have mini surges during the cold months, big surprise, but they won't be as severe as the prior parts of the pandemic. Fingers are crossed. So that's kind of where we're at with Omicron. As a related note, in terms of vaccine efficacy, the mRNA vaccines by Pfizer and Moderna are retaining protective efficacy, not as high as they had against Delta and certainly the prior variants, but especially in those who are fully boosted and those who are immunocompromised who receive even a fourth dose, data from Israel would suggest that those patients are enjoying a relatively comfortable protection, and if they are having breakthrough infections, it is asymptomatic or mild. So great, wonderful, fantastic. The story is not so rosy for the monoclonal antibody cocktails, which we have available. And unfortunately, the products from Regeneron and Eli Lilly have lost any major protective efficacy or prophylactic impact against the Omicron variant. The remaining monoclonal antibody product, which is out there and is in use, certainly in Arizona, is sotrovimab, and that does retain a fair amount of protective and prophylactic efficacy. So fingers are crossed that it stays that way, and we'll see how all that plays out. A brief word about the two new antivirals, one from Merck, which is molnupiravir, and one from Pfizer, which the product name is Paxlovid. It's a combination of two drugs which are protease inhibitors in their function, just like we use in patients who have HIV/AIDS. In fact, one of them actually is a protease inhibitor that we use in patients with HIV/AIDS. So those two drugs, the molnupiravir from Merck is 30% effective, including against Omicron variant. The Paxlovid from Pfizer is 89 to 90% effective in mild disease, both of those if they're started in the first 3 to 5 days of illness, which is great. That's wonderful. There's certainly a wonderful potential impact in this pandemic. The problem is that neither has yet been produced in large numbers. So they are being reserved, or restricted, I should say, to those who are age 70 and older with significant underlying comorbidities. So not yet for pediatrics, and certainly the initial safety and efficacy studies by both manufacturers for both products were not done in major pediatric populations. So stay tuned for more. Hopefully, if we indeed enter an endemic phase of SARS coronavirus 2, we won't have need for these, but we shall see. We shall see. All right, so going on then to the CDC recommendations in terms of quarantining and exposure and stuff like that. I imagine all of us have seen a whole bunch of noise, both in the media as well as in scientific and listserv circles. Certainly I have. I think that there are some concerns and reservations about the recommendations. Briefly, what are they? So specifically starting with healthcare personnel, so all of us and those in our offices, practices, emergency departments, etc. So a healthcare provider of whatever generation who has received full vaccines and our booster dose does not need to quarantine if we're exposed if we remain asymptomatic. Of course, if we develop symptoms, then we do need to undergo testing, quarantine until negative. So that's a big thing. So that exposure, I saw the patient in clinic yesterday, tested and they were positive. There was a mask, oops, or something, obviously a high risk exposure. We would not need to quarantine if we are fully vaccinated and boosted in that situation. Those healthcare providers who have not yet received their full vaccine or their booster dose and experience the high-risk exposure do need to quarantine as typical for 10 days. However, if we are at a time of high demand, like right now, they can actually come out of quarantine after 5 days if they do a test to stay strategy. So just like is being proposed for schools, including schools in Arizona, if they test negative every other day after that exposure, then they can come back to work, obviously wearing their masks. Those healthcare providers who have acquired natural COVID-19, regardless of their vaccination status, can come back to work after 7 days. So not the 14 that it used to be, not the 10, but after 7 days if they have a negative test and if they're asymptomatic. Even if they're symptomatic, the fever should have resolved without antipyretics prior to coming back. And if they are in an area of high demand, let's say, any of us who is in an underserved area and there are no other providers, et cetera and so forth, then that individual can come back, even if still symptomatic, at 5 days out from onset of their diagnosis. Even without a negative test, they would of course need to hopefully be mildly or asymptomatic. They would hopefully be wearing their masks extensively. But this really loosens the protocols for healthcare providers. In the community, it's even looser. So anyone of our general population, our patients, who is infected with SARS-CoV-2 can come out of quarantine just 5 days after their initial test if they're asymptomatic, and no test is required. This is a big one, and I think that the no test required is what is getting a lot of gnashing of teeth and wailing, which is, holy cow, what if they're still test positive? They would obviously or potentially still be contagious. However, CDC is not yet backtracking on that, although they're considering it, and they're pointing out to the fact that Omicron is far more infectious, but far more rapid in its onset and offset for contagiousness. So individuals with Omicron are contagious 2 days prior to symptoms and diagnosis and just 3 days after. So CDC would suggest that a 5-day quarantine after testing positive is more than adequate for the contagiousness of that patient to resolve. Yes, they would still need to wear a mask for the next 5 days. So the overall need to avoid infecting others period is still 10 days, but they can come out of quarantine, they can leave the house, they can go to school, they can go to work if 5 days after diagnosis, if they wear a mask for that next 5 days. In terms of those who are exposed, anyone in the public who is fully vaccinated and boosted and is exposed to COVID does not need to quarantine at all, period. But they should wear a mask for 10 days after exposure. Those who have not yet received their booster or full vaccination series who are exposed in the public can come out of their quarantine after 5 days if they wear a mask for another 5 days. So those are the general recommendations for healthcare providers and for those in the community. There are specific recommendations for kids. And these were just posted by the CDC on its website and on the AAP website. So you can certainly look those up for yourselves. But to briefly summarize, if an exposure has occurred in a patient who's 18 and older, so again, not likely to be our population, but we may have some still in our practice. If an 18 years old and older who is fully vaccinated and boosted is exposed, they do not need to quarantine at all, period. If it is a patient of ours who's aged 5 through 17 and has received their first 2 doses of the Pfizer vaccine, they do not need to quarantine if they're exposed. Fantastic. And any of our patients who actually had actual COVID-19 and is subsequently exposed to somebody else, if they're less than 90 days out from that from that natural infection, they also do not need to quarantine. So that's pretty permissive, especially for our kids 5 through 17 who so far have not been boosted, and more about boosting recommendations in just a second. But so 2 doses of Pfizer for 5 through 17 and exposed, they're fine. They do not need to quarantine. They can go to school. Of course, they do need to wear a mask, which in large part is being accomplished in school settings anyway. But other than that, they can go to school. Those who are not meeting those criteria, so children any age who have not fully vaccinated or older than 18 who have not been boosted, if exposed, would need to quarantine. But again, it's just quarantine for 5 days and then out with the mask for 5 more days. So that's the exposure. What about those who are actually COVID positive? So we make a diagnosis today. That child, whatever age, needs to isolate only for 5 days at home and then can come out of isolation if they wear a mask for the next 5 days. So very similar to what I just shared with you for the general public. So there you go. You'll note that in no part of those recommendations did I add in the need for negative tests. And as noted, CDC is receiving a lot of pushback on that from those who are concerned about the possibility that our exposure and or our infected person was infected not with Omicron, but with Delta, which is still potentially hanging out in parts of the country. Arizona PS is not yet to the point of 95+% Omicron variant, so we still have a significant amount of Delta hanging out, which may still be so for the next week or so. So there's a concern there that Delta behaves differently, may persist and be contagious longer than what is being released for Omicron. And the other part is just, I think we're so gun shy, unfortunately, with what happens with these variants, and we don't know yet exactly how it's going to behave, that it makes many of us nervous to allow potentially infectious people back into the community without at least confirming that they're test negative. But I'm sharing with you what the official recommendations are, and think if it is actually true that Omicron behaves as we are now thinking that it does, then those recommendations are not totally unreasonable. I'm not giving you a formal recommendation either way. Obviously, we'll need to see what happens going forward. Okay, well, one final point, by the way, about isolation for those infected and quarantine for those exposed. The periods of isolation and quarantine start from the time of diagnosis, not, and according to the CDC, not from the onset of symptoms. So it may be that the patient comes to you with 2 days of respiratory symptoms and is confirmed positive at that point. That day is day 0. The next day is day 1 of their isolation period. So the times for 5 days of isolation or 5 days of quarantine start the next full day after diagnosis or after known exposure. Okay, to the boosters. So a lot of noise there as well. First of all, I think we saw earlier this week that the FDA has given its approval for a booster dose of the Pfizer vaccine for those ages 12 through 15. Previously, FDA and CDC have approved Pfizer and Moderna booster doses for those 16 and 18 years of age and older. And in fact, there seems to be some gray zone in approving Moderna vaccine boosters for those 16 and up. Keeping in mind that the emergency use authorization for Moderna initially was 18 and up, and they're still considering that data for the ages 12 through 17 for Moderna. However, whichever vaccine one happens to have in the practice, presumably it's mostly Pfizer for those of us who are pediatric only, but Pfizer boosters for those ages 16 and up. FDA has approved boosters for 12 through 15. The CDC and Dr. Walensky, the director of CDC, are expected to release a formal recommendation supporting that recommendation from FDA anytime this week. In fact, perhaps by the time you're already hearing this, that approval may already have occurred. So I think we can reliably anticipate CDC will also support booster doses for ages 12 through 15. Are they necessary? This is a big question that I'm certainly getting from providers locally and parents as well. And that's a tough one because, as you'll note, the quarantine recommendations for exposure for ages 5 and up does not include booster as a requirement. However, I think knowing that Omicron is infecting those who are not boosted, knowing that as it becomes more and more contagious, will certainly target the pediatric population more successfully, I think it is reasonable both for personal safety of our patients and also for societal safety to reduce circulating viral load, that we should be boosting every single human being that we can as soon as we get that emergency use authorization. So stay tuned. Should the CDC already have or be about to approve boosters for ages 12 through 15, I would suggest we do that. The CDC has already approved a booster dose for children ages 5 through 11 who are immunocompromised. And of course that makes sense, because we are seeing that those who meet criteria for immunodeficiency, immunosuppression, or being immunocompromised are not having a completely protective response after 2 doses or sometimes even 3 doses. So those who are on chronic steroids, certainly those who are on immunosuppressive medications, our children with varying oncologic diseases, our children with certainly HIV/AIDS, all those individuals, if they are 5 and older, now deserve a booster dose of the Pfizer vaccine. So that's we're getting there. We're getting there for getting everyone boosted. And then finally, the time period to give the booster dose for Pfizer vaccine has been shortened from 6 months down to 5 months. That's based on data provided by Pfizer that its booster is as efficacious at its boost phenomenon at 5 months out as it was initially reported to be at 6 months. Great, wonderful, fantastic that every month, to get more people boosted, if they will, is going to help in terms of risk for Omicron variant infection. The recommendations, however, have not changed for a boost dose of Moderna. That is still 6 months after their second dose. And for anyone who received the Johnson & Johnson vaccine, and again, this is really not our patient population because that's only emergency use authorized for ages 18 and up. But should we have perhaps a parent who asks a question or an older, like a young adult in our practice still, if they got a single first dose of the J&J vaccine, they still can get a second dose of J&J 2 months out. However, the data has certainly shown that a person who received a Johnson & Johnson vaccine does far better and has a far higher seroprotective boost if they get as their second dose either Moderna or the Pfizer mRNA vaccine. And in fact, CDC and FDA and Human Health Services, the entire country has really gone cold on the Johnson & Johnson vaccine due to the associated risk of the vaccine-induced thrombotic thrombocytopenia. Since there are cases that have unfortunately resulted in fatalities, and the risk, while still remote, is not zero. So the J&J vaccine is really not preferred at this point. One of the mRNA vaccines is preferred. Of course, and again, that point is largely moot for pediatric patients, but at some point in time, we may encounter that question in our practices. So that's where we stand, folks. There's a lot going on. Hopefully, every day will represent some additional information about Omicron, and every week will hopefully represent a decrease in the surge. And perhaps in several weeks or several months' time, we'll be starting to breathe more comfortably and perhaps entering the endemic phase of COVID-19. Certainly, fingers are crossed. I've been asked multiple times, are there any other variants out there? And the short answer is, well, there's always going to be additional variants, but it's going to take a monster variant with even higher infectivity and higher fitness to achieve the ecological niche that Omicron currently has been doing. Certainly, every time a new variant has emerged, it has had a survival advantage over the pre-existing and currently circulating variants. That's how Omicron has taken over the world versus Delta, which itself was no wallflower. So I think it is increasingly unlikely that yet another variant could come out which has any additional survival advantage or is any more fit than Omicron currently is. So the initial predictions, and hopefully this is true, are that this may be the last variant and the last variant-associated surge that we'll experience. And if so, we may be, as we speak today, beginning to see the end. Fingers are crossed. So with that hopeful note, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. The AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, hang in there, have some hope, and Happy New Year.